Hey everyone, we're back here at Giraffe with another video for surgery clerkship preparation for medical students. This one is starting the topic of surgical nutrition. There's several aspects that go into surgical nutrition, but we're going to just cover enteral access at first. If you remember nothing else, always know that enteral nutrition is always better than IV nutrition. It's both able to be more complete, it's cheaper, has fewer side effects. But when we talk about enteral nutrition, it can be pretty confusing because it's essentially an alphabet soup of a bunch of different types of tubes. It can be tough to keep track of which is which or to explain that without the assistance of some drawings. So that's what we're going to talk about today. All right, so there's really two main functions of these tubes. Either they're there to provide nutrition, like we talked about, or if there's a backup, either a bowel obstruction or something like an ileus, which is just when the intestines kind of slow down for a while and fluid builds up. It can be used to remove those contents so they don't um, build up in the stomach or the intestines, then back up and cause people to vomit, or worst case, vomit and then aspirate some of that vomit into their lungs and have a severe aspiration event or aspiration pneumonia. All right, so the first type of tube that we're going to talk about is called an NG tube or a nasogastric tube. So as you can probably guess, starts in the nose and ends in the stomach. So tracing a course something like this. And what I want to point out too is that it's usually a little bit thicker tube or a wider diameter. That's good because usually you're using these to help suck things out. Although, of course, you can deliver meds down these tubes as well. You just pause the suction for a while you're giving the medications. These tubes also have two lumens. So if you can see this clear lumen right here, that's the main lumen. That's where everything is getting sucked up and out of the tube. But there's also this blue lumen. So these are called the Salem sump, and this blue port is the sump. And if you're not too familiar with what a sump is, basically this blue port is just allowing air to pass through this way, um, actually all the way down the tube and out into the belly. So it provides, it essentially prevents a vacuum from forming. So, right, so we've got a suction here, stuff getting sucked out up through the clear part of the tube. You can't see it, but the blue part actually lets air come back in and replace the space that's lost as contents get sucked out. You can actually hear whistling coming from this end of the tube when it's working properly. It's sucking out here and the air is sumping down and whistling, and you can tell that the tube's in the right place. It's not blocked up and things are getting sucked out just the way they're supposed to. The next tube is the Orogastric tube, or the OG tube. So as you can guess, starts in the mouth this time instead of the nose, and then goes down and terminates in the stomach. So the reason you would put a tube down the mouth as opposed to the nose, usually the nose is more comfortable to just deal with on if you have it in for a prolonged length of time, essentially. As you can imagine, in the mouth, it goes by the uvula, things like that. That can be really obnoxious to deal with if you're awake. So people who have OG tubes are typically, it's placed while they're in the operating room to help prevent aspiration with anesthesia, or in somebody who's intubated and sedated, then it's much easier to place an OG or a gastric tube as opposed to an NG tube. So you could have it in there. But usually when you go to intubate them, you would pull out the OG tube and the ET tube, or the endotracheal tube, at the same time, because as you can imagine, having a giant tube sticking out of your mouth would be super obnoxious. And then as you see over here, we have that same bigger, sturdier, wider diameter Salem sump style tube, just like we saw for the NG tubes. All right, so getting a little bit different here, we have our next tube, which is the NJ tube, or nasojejunal. Once again, it's all in the name. N starts in the nose, travels down the esophagus. This one's jejunal, though, so it actually passes through the stomach, into the duodenum, and then obviously passing behind the colon here, and ends up somewhere in the jejunum. And the type of tube we see here, we see our first different kind of tube. So you see this tube is much thinner. It's less robust than the Salem sump tube. This is commonly called a Dobhoff or a feeding tube, and its primary use is for giving feeds or giving medications down the tube. You would not use this tube; it's too small to suck anything out of the abdomen, of the lumen of the GI tract, I should say. The key here is that this tube is a feeding tube, and frequently people put it in the jejunum all the way down here because they think that passing the pyloric sphincter makes it less likely for whatever you're giving in this tube to build up in the stomach and then cause you to throw up or aspirate. However, it's equally common to have these tubes in a NG position, so a nasogastric feeding tube, which would just be in the stomach giving feeds here. And as long as your stomach works okay, there's no reason not to. If you had something like gastroparesis or an obstruction in your stomach where you couldn't pass liquid out there, you'd want the tube to be more distal in the nasojejunal position. All right, so now we've moved from tubes that you can essentially place just through natural orifices, the nose and the mouth, and moving towards tubes that require procedures to get put in place. So this is a gastrostomy tube, or a G tube, as you can imagine from the name. It goes into the stomach. Usually these are placed surgically, either laparoscopically or open. The goal is to overlie the stomach with where the tube goes in on the skin. It should be a couple finger breaths at least below the rib cage because it can really irritate that costal margin if it's too close. So you want to make sure you're avoiding that. And you also want it close enough, or I guess I should say in the right position relative to the midline, so you're over the rectus muscle. If there's muscle around the tube, it kind of creates a nice seal and is less likely to leak around the tube. So that's where we're usually trying to place it. When it comes to the tube itself, it's usually these pretty small tubes. These are called buttons, but you have these ports to attach to and give feeds. You can give feeds, you can give meds. You don't really want to apply suction to these, but if somebody does have an ileus or is backed up for some reason, you can do what's called venting the G tube, where you just open it up and allow contents to kind of fall out to a gravity bag. But you wouldn't hook it up to suction like an NG tube, for example. And then you also have the side port. That's for putting the usually sterile water or even tap water in the balloon. You don't want to use saline because that will crystallize, could cause the balloon to burst or not hold its seal. And that balloon, so I guess to orient here, this is outside the body, this is inside the body. So it goes in this way through the skin, and then you inject your water through here to inflate your balloon, and this balloon is what's holding it in place, keeping it from being pulled out. And of course, this button keeps it from being pulled in or getting lost inside the stomach. All right, so a PEG tube, this is essentially a G tube that's just placed in a different way. So you see the G tube is all the way in the name. PEG stands for percutaneous endoscopic gastrostomy tube, which has to do with how it's placed. So there's two ways to place this. The most common way, in my experience, is called the pull technique. And basically what you do is you stick an EGD or a scope down into the stomach. And then while you're looking at the stomach here, maybe I'll draw it over here. So we've got the skin here and the abdominal wall here, and then the stomach underneath. So you have your scope in here, and you're looking up at the abdominal wall. Once you're in the right place, you actually take a needle from the outside and poke into the stomach with this needle, and you pass a wire through there. And you actually use your scope to grab this wire and pull it up and out. So if you can imagine, now we've got a wire coming from outside the body into the stomach, and then it's gotten pulled all the way up through the esophagus and out through the mouth. And then this wire hooks onto your PEG tube, like this. And then you actually pull the wire in this direction, pulling the PEG tube all the way down and through the stomach. So in this case, it's a balloon, but oftentimes it will just be like this mushroom tipped piece of plastic. at the end of your PEG tube until that runs into the abdominal wall. So you got your stomach, and you got this mushroom. It's not a great drawing. Tube pulled up against the abdominal wall there, and you have a little circular flange at the top holding it into place. But that's all kind of detail stuff that your residents need to worry about. But what you need to know is a PEG tube is just a G tube. So it's a tube that comes from outside, goes into the stomach. And so it does the same thing that a G tube can do. So you can give food or feeds or meds into the body, or you can open it and vent it to gravity to allow some extra fluids from the stomach to run out. All right, so now that we've covered a G tube and excuse me, a PEG tube, we'll move on to gastrojejunostomy tubes, so G and J. So if you can imagine, it's just like your G tube, which comes from outside the body and sits in the stomach. It also has a second extension that goes through the stomach, post-pyloric, and then ends up in the jejunum. So once again, we can do everything we did with the G tube. We can give feeds or meds, but this time we can give it, as you see, there's a gastric and a jejunal lumen. So we can either give feeds or med into the stomach, or we can give feeds or meds into the jejunum. We can also potentially open the stomach and vent the stomach. You wouldn't really do that with the jejunum, but you can do that with the stomach. In a rare case, you could potentially be giving feeds to the jejunum and venting the stomach, once again, something like gastroparesis. All right, and then as you can imagine, a J tube is just very much like a GJ tube, but without the gastric component. So this one goes through the skin and into the jejunum itself and just gives feeds there. You wouldn't really use this for venting. It pretty much is only for giving feeds and meds. All right, so that wraps up our video. Like I said, alphabet soup, a lot of stuff to think about and remember, but I think if you just remember that pretty much all those letters, if you just translate them, they tell you exactly where the tube is. So naso versus oro in the stomach or the nose, in the mouth or the nose. And then G or J is telling you if it's in the stomach with the G tube or the small intestines with the J tube. And remembering that you typically can vent or feed through the G tube, but the J tube is almost always just for feeding. And then you saw the couple different types of tubes that go through the nose, the thinner feeding tube or the thicker Salem sump tube that can give meds or suck things out. All right, so I think that covers everything I wanted to cover. Let us know if you have any questions or if anything was unclear. These videos are for educational purposes only. Don't use them to diagnose or treat any diseases. And this was made with Edgeraffe Studio, repairing surgical education one image at a time. Thanks.